Good morning. The first case for the Pediatrics USMLE Step 3 board review course will be the chief complaint of a red eye. If you look at your history, what you see is that a 16-year-old comes to the office with a 2-day history of a watery red left eye, and the patient has a yellowish discharge. The patient's also reporting that she has crusting upon awakening. She denies any eye pain and does not recall any trauma to the eye. Physical examination reveals a diffuse conjunctival hyperemia of the left eye, which is associated with mucus discharge, and pupils that dilate normally, with mild photophobia in the affected eye. There is no adenopathy. The fundoscopic examination, the eye movement, and the visual acuity are all normal. Now, the first thing that you want to be thinking about when you approach this case is to pick out buzzwords that will help you analyze and to formulate a differential diagnosis. For instance, if you look at the words watery red left eye, the first thing that you want to be thinking about is, could there be trauma? Could there be a glaucoma? Could there be a conjunctivitis? Well, if you move on into that paragraph, you see that they also say that the patient has yellowish discharge. This gives you a hint that there is evidence of infection. Now, if you move further, we see that there's the word crusting. So in the morning when the patient is waking up, you're finding that the patient's eye is closed shut because of crusting. The other thing that you want to be thinking about is, how is the visual acuity? What do the pupils react as? Because we want to make sure that we have a normal eye. Now, if we think about our differential diagnosis, we've talked about a few of them. We've mentioned bacterial conjunctivitis. We've mentioned viral conjunctivitis. We've talked about glaucoma. Other things that might cause you to have some purulent discharge or some wateriness to your eye would be corneal abrasion, and also an allergic conjunctivitis. So what's the first step? What would you need in order to make the diagnosis here? Well, the first thing that we need to do is the Snellen and Sharp visual acuity. The other thing that we need to be thinking about is a fluorescein eye stain. Why are those your two most important steps? Well, you need to make sure that the patient can see and that they have a good visual acuity. The other thing is as far as the fluorescein staining of the eye, we want to make sure that there's no foreign body, no corneal abrasion. Now, if you look at your results, we find that the visual acuity is normal and that the fluorescein staining of the eye was also normal. You saw no corneal abrasion. So, how do we assess this? Well, first of all, once I find out that my pupillary dilatation is normal, then I can pretty much rule out glaucoma. If I had a viral conjunctivitis, usually that's a watery discharge, and it's usually a bilateral discharge. And you may also see that the patient may have some preauricular adenopathy. However, the culture would not routinely be performed to rule viral versus bacterial, because by the time you got the culture results back, what would happen would be that the patient would already probably have his conjunctivitis resolved. The other thing that we want to make sure that we think about is uveitis. If you have somebody that has uveitis, then we need to really be thinking that the patient would have a painful eye. In this particular case, you don't have any evidence that there's pain. Therefore, uveitis would probably be slight on your list. As far as the history of crusting, this is more characteristic of a bacterial versus a viral conjunctivitis. And again, your fluorescein stain is ruling out any ulceration. Now, how would you approach this particular patient? If you've come to the conclusion that you have bacterial conjunctivitis, it usually will resolve after several days. However, you may want to use some type of a topical antibiotic might be helpful. However, the key is to never use topical steroids. This would be really a problem, a serious problem, especially if you had herpes. So you want to make sure that you star that point. Now, in your differential, we talked about viral conjunctivitis. And what we need to be thinking about here is that on the exam, the examiners will probably be wanting you to be able to differentiate the viral versus the bacterial. Remember that if you have a watery eye discharge with no evidence of purulence, that they would want you to choose the next step as it will resolve on its own. All right? So don't be giving any antibiotics or any medication because you would be marked wrong, because we never treat a virus with an antibiotic. So that would be another take-home message for that. As far as the final diagnosis for this particular case, it's bacterial conjunctivitis. And if you look at your notes, you'll see that we have some case reviews. And the case reviews are there to help you glean the key points as far as the buzzwords that might help you to pull out a differential diagnosis. For instance, for bacterial conjunctivitis, we said that there was a red eye with discharge, history of crusting. It's a painless problem, and that topical antibiotic therapy would be warranted. For viral conjunctivitis, we said that it's associated with an upper respiratory infection, and you're going to look for clear discharge. You may see even some adenopathy. The other thing that you want to be thinking about is glaucoma, and we said that that would be a painful eye, that there would be an abnormal pupillary response, and that the ophthalmologist consultation would actually be imperative. The other thing that we want to make sure that we think about are uveitis and corneal abrasion, that it's painful, that there's photophobia, that there may be trauma with abrasion, and that there's a fluorescein stain necessary to rule this corneal abrasion out. Now, just as an aside, if you have a patient that is a neonate and they present with a discharge, what you need to be thinking about as far as the eye discharge is that does this patient have ophthalmia neonatorum? And the key here is to remember that in the first 3 days of life, an eye discharge is normal. Why? Because the baby's going through the birth canal, picking up any organisms with their eyes open. You go and you're going to put some solution into the eyes. Okay, that's supposed to cause a chemical conjunctivitis. And in the first 3 days, that would be considered physiological or normal. However, what you need to be thinking about is from day 3 to 5, or this would be suspicious for GC. And in that particular case, what you would want to do is to do a gram stain and look for gram-negative intracellular diplococci. All right? So that would be your next step, and that would be the key. The other things that you want to be thinking about for eye discharge in the neonate would be that the patient who is greater than 5 years of age, who has a small white discharge or copious amounts, may have a chlamydial infection. So in addition to doing a gram stain, you want to make sure that you always do cultures in the neonate so that we can rule out chlamydia and gonorrhea. All right? So that would be one exception to the getting the cultures for conjunctivitis. We're going to go on to the next step, or the next case, which is rash on the legs. We're going to look at the history, and what we see is that we have a 6-year-old boy who was brought to the office because of a rash that started as a superficial accumulation of small vesicles on his legs below the knees. There's no fever or chills. He lives in the suburbs and often walks outside in the local woods. in short pants. Vital signs are a temperature of 98.6, blood pressure of 120/70, a pulse of 65 per minute, and respirations of 12. The physical examination shows honey brown crusted lesions with an erythematous base on both legs. There are other lesions present, which are in various stages of crusting and openness. The examination is otherwise normal. So we want to be thinking about our differential diagnosis. One of the first things that we need to be thinking about here is, does this person have a cellulitis? Other things that might come into thinking about is this erysipelas? Could this be impetigo? Or could this be varicella? So we have to think about what would be our next step as far as the initial diagnostic plan. And the next step, if we did anything, would be to culture the skin lesion. However, I want to make note here that this is not routinely done. The diagnosis really should be able to be made just by clinical observation. However, if you did do a diagnostic plan as far as culture of the skin lesion, you would see that the patient had group A strep. So again, as far as our assessment, if you think about it, what is impetigo? This patient has impetigo. It's a superficial skin infection. Why did this particular patient get it? Well, he was out in the woods. He probably got a cut on his skin. We have organisms on our skin, strep and staph, and so he developed a small skin infection. Remember that in this particular case, in this description, this is a more traditional impetigo. There are two types of impetigo, strep impetigo and staph impetigo. All impetigos have a component of staph. All right? You need to remember that. All impetigos have a component of staph. Therefore, when you're making your next step for treatment, you need to realize this in order to choose the appropriate antibiotic. As far as the causes, if you have hot, humid weather, poor hygiene, overcrowding, all these can cause impetigo. The key word or the buzzword would be honey-colored scabs. So that's a buzzword that would just automatically point to a traditional impetigo. Now, if we look at erysipelas, this is somewhat deeper, and it usually occurs in the dermis. However, how you can tell this is that there's really no weeping lesion, that it's usually caused by strep. Cellulitis is deeper still and involves the dermis and the subcutaneous tissue. The cause is almost evenly divided between the staph and the strep. And the diagnosis in all three of these is almost always based on appearance. As far as our treatment plan, topical antibiotics would be appropriate if you had a mild impetigo. However, if you had a widespread impetigo, topical would not suffice. Therefore, you have to think about how extensive is this impetigo. Sometimes what happens is you'll have a child who's been wiping his nose, okay? So the nose has been dripping, he's been wiping, and you'll see that the staph or the strep from the nose puts a big impetiginous lesion in front of the mouth or on the nose. Now the child is, spreading it to other parts of his body, and it may be extensive. Therefore, you would not be able to use topical antibiotic. In this particular case, you would want to use oral antibiotics. Now, we said that the component is strep and staph. Therefore, antibiotics such as dicloxacillin would be appropriate if more severe. Looking at our case reviews, remember that for impetigo, it's a superficial infection of the epidermis. It's usually caused by group A strep. It's associated with hot conditions, poor hygiene, and crowding. And that the buzzword that you're looking for is honey-colored crusted lesion. The other thing that we want to make sure that you realize is that topical antibiotics for mild disease, systemic antibiotics for more severe disease. Differentiating that from cellulitis, it's a deeper infection. There's erythema and tenderness in cellulitis. There's no crust or vesicles. And if they asked you what the next step of management or treatment would be, you would say that you were going to do a leading edge culture. And what that means is that you're going to take a small amount of saline in a syringe, and you're going to insert the end of the syringe, the tip of the needle, into the leading edge of where the cellulitis is. You're going to push some of the saline in and then pull back. And that's going to be a culture for you to determine what type of organism you have and what you actually need to be treating. As far as erysipelas, remember it's entirely in the dermis and that there's no weeping, and that varicellas come in crops of lesions. The varicella would have buzzwords such as pruritus. The patient would have fever. The patient may have had URI symptoms. And the patient would have vesicles and crusts that are in various stages. Remember for your varicella that it starts on the thorax and extends to the extremities. And remember that the child would be contagious until the last vesicle is crusted. The next case that we're going to do is a neonate who presents who has nasal flaring, cyanosis, and grunting. You have a 17-year-old African-American girl with an unknown last menstrual period and no prenatal care who comes to the emergency department complaining of contractions every 5 minutes. The obstetrical ultrasound is consistent with gestational age of 28 weeks. The estimated fetal weight is 1,000 grams, and the baby is noted to be in the breech presentation. The patient is immediately started on mag sulfate for tocolysis and betamethasone for fetal lung maturity. The contractions start to space out within an hour, and the patient is transferred to the antepartum service. 48 hours later, what we find is spontaneous rupture of membranes, which are confirmed, and that the patient now is going to be transferred to the labor and delivery floor for further monitoring. The patient is prepared for an emergency section, which is uneventful. You have a female infant which is delivered, and APGAR scores are 7 at 1 minute and 8 at 5 minutes. They're also done at 10 minutes, and we have another APGAR score, which is 8. The baby weighs 1,140 grams. This baby is transferred to the neonatology intensive care unit. Within an hour, the baby develops tachypnea, nasal flaring, subcostal and intercostal retractions, cyanosis, and expiratory grunting. Now, the important thing here when we're thinking about our history is to make sure that we get the buzzwords tachypnea, nasal flare, subcostal and intercostal retractions, cyanosis, and expiratory grunting. Remember that grunting is a sound like The baby is trying to give themselves peep, all right? Grunting is an ominous sign. Cyanosis in an infant would be an ominous sign. Therefore, you need to make sure that you do something immediately. You need to critically intervene. Now, interesting, you might say to me, but I looked at the APGAR score, and the APGAR score really wasn't that bad. This baby had an APGAR score of 7, 8, and 8. What I want to remind you is that the APGAR score is only telling you what that baby is doing at that moment in time. Okay? It doesn't predict what the baby's going to do an hour from now, 2 days from now. It doesn't predict that the baby is going to be more intelligent the higher his APGAR score is. It only predicts how the infant was doing at that moment in time. Now, you need to be thinking about, if I was a term infant, then probably an APGAR score of 8 would be okay. And probably, from my experience and your experience, you'd say that most of those children would do well in the normal nursery. However, what you need to be thinking about with a baby that's this small, this premature, that this baby is being stressed. This baby's being stressed by the environment. This baby's being stressed probably secondary to the lungs not being mature. Therefore, within an hour, the baby ran into trouble. And so you need to be catching that last point, tachypnea, nasal flare, subcostal intercostal retractions, cyanosis, and expiratory grunting. Now, if we think about it, what are some of the things that could cause difficulty with breathing? Well, the first thing that you might be thinking about would be pneumonia. And if you had a pneumonia in this child, sure, this patient could have cyanosis. This patient could be grunting. This patient could be in respiratory distress. What other things might you consider? How about meconium aspiration syndrome? We know that when patients have meconium aspiration syndrome, that they can run into respiratory distress. It can be so critical that they can even die. Other things that we might be thinking about here are the respiratory distress syndrome. Again, the classic words, tachypnea, cyanosis, grunting, a premature baby. How about transient tachypnea of the newborn? Usually those babies will run into a problem about an hour after birth. But usually, and those patients are with C-section, all right? Usually the history or the buzzword might be that the patient would have a C-section. And no one really knows what causes transient tachypnea of the newborn, but they think that it's attributed to the lack of not going through the compressions during the labor period, all right? So you don't really get out the excess fluid. The other things that you want to be thinking about are non-pulmonary causes, hypothermia, hypoglycemia, anemia, polycythemia, metabolic acidosis. So what would you do first for this particular patient? Well, you have a problem with the lungs. The first step really is to intervene, give oxygen. If you feel that you need to intubate, intubate. But what will make your key diagnosis? A chest x-ray, all right? And if you look at the results, what you figure out here is that you see a ground glass pattern. Anytime you see the words ground glass, what you need to be thinking about is, does this person have respiratory distress syndrome, oftentimes known as hyaline membrane disease, all right? The only other time they use the buzzword of ground glass is sometimes in accordance with chlamydia pneumonia. All right? So now you're scoping down onto your differential diagnosis. They're giving you ground glass pattern. Now, as far as the assessment, if we thought about the meconium aspiration syndrome and transient tachypnea of the newborn, generally these are going to be considered a diagnosis of the third trimester. You have a premature baby. So these are really ruled out. So instantly you can rule those out. The bowel isn't really mature enough for an infant of this gestational age to release meconium in utero. Why? Because it doesn't have the neurological regulation for organized peristalsis. Also, the other thing that you want to be thinking about are that babies at this gestational age and weight are at increased risk for respiratory distress syndrome. So what's your next plan? What do you further do? Well, first of all, anytime you have a sick infant, you need to go back and get a good history from the mother, all right? You want to also make sure that you do routine labs on the mom. So as far as the mother, you want to look at vaginal aerobic cultures, the urinalysis. You want to look at CBC and urine toxicology. Why are we looking at urine toxicology? Sometimes these small premature infants have been exposed to cocaine or to drugs in utero. As far as the results of the mother, they're normal. Other things that we need to be thinking about are fetal. What are we going to look at as far as the infant? What would be important tests that you would want to consider or important information that you would want to know? Well, first of all, you'd want to look at an artery blood gas, an umbilical artery blood gas. And with that, what we're finding, because this person is in respiratory distress, it's no surprise. The oxygen is decreased. The other things that you want to be thinking about are looking at a CBC and a blood glucose at the bedside. And these are normal. So you need to be thinking now, how am I formulating my diagnosis and what will be my next step of treatment? Okay? I think that we're all in agreement that the patient has respiratory distress syndrome. And the first thing we want to do, since the patient is cyanotic and grunting, and we said that grunting and cyanosis are ominous signs, is we want to intubate the patient with 100% oxygen. The second thing that we want to do is make sure that we get surfactant therapy, multiple doses on board. Why are we giving surfactant? In order to aid in the maturity of the, or the development of the lung. Other things that we want to do is to wean the patient off of a mechanical ventilation as tolerated as soon as possible. Now, as far as conventional therapy for the premature infant, remember that many times it's supportive. Oxygen administered is often necessary, often helpful because of the lack of lung development. And again, what we want to be thinking about is that if we were thinking about respiratory distress syndrome, that constant feature of RDS is that it typically will start within an hour of delivery. All right? So a premature infant who runs into respiratory distress, think the respiratory distress syndrome. Looking at our case reviews, what we want to be thinking about here is buzzwords or things that will help us in summary. And we've said that respiratory distress syndrome gives us early onset of respiratory distress. It's due to surfactant deficiency. That the chest x-ray shows a diffuse reticulonodular pattern, or often referred to as ground glass pattern, and it shows air bronchograms. So if you see ground glass, or the buzzword air bronchograms, or a reticulonodular pattern, your diagnosis should lead you to respiratory distress syndrome. And again, the way you're going to manage that is with intubation and surfactant therapy. As far as pneumonia, you would usually see a lobar infiltrate on chest x-ray. And what you need to be thinking about as a practitioner is what organisms would give me pneumonia in this particular age group. The organisms that you need to be thinking about would be group E strep, Listeria, and E. coli. Why is that important to know? It's important to know because in this newborn infant, these are the organisms that they would be exposed to. In order to make your treatment, you would need to decide what antibiotics you needed. The other thing that you need to know is that if the infant did have pneumonia, that this patient would need a complete septic workup. What is that complete septic workup? It would be a CBC. It would be include a urinalysis and culture, a blood culture. You would have a chest x-ray in this particular case because of the respiratory problems. And you would also include a lumbar puncture. So any neonate that you suspected had a serious infection, such as pneumonia or urinary tract infection, needs to have a lumbar puncture. Now, we said that we were thinking about organisms group E strep, E. coli, and we were also thinking about Listeria. Your job on the examination and as a physician would be to think, what particular antibiotic would I use in this case? And the antibiotic that you would use would be ampicillin and an aminoglycoside, or ampicillin and cefotaxime. Now, why do I have to use the double therapy? Well, first of all, I have to be thinking about the organisms again. You need to have ampicillin and aminoglycoside for synergy, but you also need to have the ampicillin because of listeria. What else do you need? We said as an alternative, ampicillin and cefotaxime. That would work. Again, ampicillin for listeria. And the thing that you want to remember is that for this cephalosporin, it should be cefotaxime. They may put other cephalosporins on your exam. For instance, they may put ceftriaxone on your exam. You would never use ceftriaxone in a neonate. And the reason you wouldn't is because it causes biliary sludge. So you need to remember that. The other cephalosporin that they may put on the exam is cefuroxime. You would never use cefuroxime in anyone that you expected had meningitis or serious sepsis. Why? Because it doesn't cross the blood-brain barrier for approximately 9 days. By the time it crossed the blood-brain barrier to treat, if there was a possible meningitis, the patient would already have neural deficit or the patient would be dead. Therefore, the treatment for the pneumonia would be ampicillin and aminoglycoside or ampicillin and cefotaxime. Now, you might say to me, well, Dr. Kerner, you told me that the other thing that we could have with the ground glass x-ray would be chlamydia pneumonia. Because didn't we learn somewhere that if the patient has a chlamydia conjunctivitis, i.e., ophthalmia neonatorum, that chlamydia may start to colonize into the nasopharynx and continue down the respiratory tract into the lungs, causing a pneumonia, i.e., causing cough breath, cough breath, cough breath, cough breath in an infant. And this is true, but think about your timing. Think about the case. Think about chlamydia pneumonia. It is going to take at least 4 to 6 weeks before this develops because the organism is going from the eye down into the lungs. All right? However, if you did have a patient who had chlamydia pneumonia, a patient who was afebrile, who was 4 to 6 weeks old, who had tachypnea, who may have had a history of an eye discharge, then in that particular case, your next step or your treatment of choice would be erythromycin. And the erythromycin that you would use would be oral antibiotic. All right? Topical won't be able to cover it. Even if you had ophthalmia neonatorum with chlamydia, it wouldn't be able to cover it because you're colonizing in your nasal pharynx. Now let's look at some of the other differential diagnoses that we had. One was meconium aspiration syndrome. What did we say we needed to be thinking about or considering for meconium aspiration syndrome? Well, first of all, you'd have meconium in the amniotic fluid. It would be brownish in color or greenish. Might look like pea soup. Could be thick or thin. All right? The other things that you as a physician in your management would need to be thinking about with somebody who had meconium present is that there would be good suctioning of the oropharynx. So as the patient comes onto the obstetrical field, you would want to suction the patient before the patient took their first breath. Why? Because if they take their first breath, they're going to inhale that right down the trachea into the lungs, causing meconium aspiration syndrome. What would the x-ray look like? Well, you would see some evidence of aspiration on x-ray. Because it's a chemical pneumonitis, what would happen would be is that it may extend over a period of time. Now, the question on your exam, if you had a person who had meconium aspiration syndrome, might be, how would I treat that? Again, it's supportive. You might have to intubate. You might have to use mechanical ventilation. However, If it's a chemical pneumonitis, you can't use an antibiotic because the antibiotic is not going to help. And remember that a meconium aspiration syndrome will predispose you to persistent pulmonary hypotension in the newborns. What other things did we mention? Transient tachypnea of the newborn. What about it? Well, first of all, we said it would be in a more mature infant. Again, we attributed it to probably a delivery that was done by C-section, or if you have a rapid stage, a second stage of labor. Remember that during labor, the patient is going through some trauma, some compression, and in this transient tachypnea of the newborn, it's thought or theorized if this patient did not go through that stage, that there may be some respiratory difficulty with fluid in the fissure. However, with supportive care, this should resolve. Okay. What we'll do right now is to take a break, and we'll come back with our next case, infant with persistent vomiting for 2 days. Okay, the next case that we're going to look at is an infant who comes in with persistent vomiting for 2 days as their chief complaint. If we look at the history, we see that there's a 3-week-old boy who's brought to the emergency room with a history of vomiting after each feed. The symptoms started about 2 days ago and have been worsening over the last 24 hours. The mother describes the vomiting as projectile and occurring within half an hour after feeding. He's appeared to be a bit lethargic over the last 12 hours. There's no history of fever or any history of diarrhea. The mother states that the infant wants to have the formula and seems to be hungry. She just fed him about 20 minutes ago, and urine was passed within the hour. If we look at the history, we want to make sure that we pick out key words. The key words to be thinking about here is that this patient is vomiting after every feed. Now, what you need to be differentiating here, is it a true vomit or is it a spit up? Because sometimes mothers will come in and say the patient is vomiting, but really what they mean is the mother burped the baby and the baby had a small amount of vomit or formula that came back, like a reflux. That's not vomiting, all right? This description, projectile vomiting, what does that mean? That means that the baby has so much force that it's going out. It's not just a little, some formula came up, all right? It could almost, sometimes we say, it just spurts out and falls onto the floor, okay? The other thing that you want to note is how does this baby look? Baby's looking lethargic. So what does that mean? Baby could be septic, or what else could it mean? Could mean that maybe the baby's getting dehydrated. All right? Other things that you want to be thinking about is that the baby, they say, is irritable, but they use the word consolable. Anytime we have the word irritable in a newborn scenario, we must always think of meningitis. Because remember that irritability may be your only sign of sepsis or meningitis. They help you out here by qualifying it. All right? They're saying that the patient is consolable. When you qualify it, a person who has sepsis or meningitis, you wouldn't be able to console. They would just be crying and crying and crying. All right? And so they're trying to help you out to make your correct choice as far as your diagnosis. You look at the skin, and the patient has average skin turgor. Now, we're going to be thinking about what does the physical exam look like. First of all, the baby is normal cephalic. The baby is atraumatic with the head. They have normal eyes. The patient also has normal ears. The nasal septum appears to be within normal limits, and as well as the throat. If we look at the neck is supple. Now, they give the word supple because of meningitis, but remember that it would be difficult in a 3-week-old to look at the neck and make your conclusion that the baby doesn't have meningitis. So you need to be still keeping that in your differential. There's no adenopathy and no thyroid masses. We're going to look at the lung, and the lungs show that the patient has good respiratory effort. It's clear to auscultation within the limits of examination. Cardiovascular seems to be normal. The patient has positive bowel sounds. There's no organomegaly appreciated. During examination, the infant has a non-bilious projectile vomiting, so you're witnessing it. On palpation after the vomit, you have a palpable, hard, mobile, and non-tender mass, which was appreciated in the epigastrium to the right of the midline. You look at the genitalia, and there's a normal Tanner stage 1. Why is this important? Well, if the patient had a congenital adrenal hyperplasia, the patient may be presenting the same way with some signs of dehydration and vomiting. However, in a male, it would be difficult just by looking at the genitalia to come up with that diagnosis because phenotypically they're usually normal. The other thing that we want to be thinking about here is that for the extremities, there are full range of motion. There's no cyanosis or edema. There's no hip click. And neurologically, the patient appears to be within normal limits. Now, if we think about our differential diagnosis, one of the things that we could be considering is gastroesophageal reflux. Gastroesophageal reflux is that spit up that we talked about. Viral gastroenteritis. Whenever you have gastroenteritis, you can end up having problems with vomiting. However, you need to be thinking, where's the diarrhea? Because with gastroenteritis, you have two components, the vomiting and the diarrhea. Other things that might present as emesis is duodenal atresia. But the thing that you need to be thinking about is that's an early diagnosis usually, and usually the vomit would be described as green vomit, not as projectile. You might have an antral web as another possibility in your differential diagnosis. And then lastly, you might be thinking about pyloric stenosis, person who has projectile vomiting. Now, you as the physician might be called on to say what the next step is, or what specific laboratory would you get in order to make or help you make the diagnosis. They may give you some components of the information, all right? If you needed to make the diagnosis and you could only choose one test, with this infant who has this projectile vomiting, which is the buzzword, ultrasound will help you to make the definitive diagnosis. However, sometimes what the examiners want to do or want to know is, do you know that really the first step would be to address hydration and to look to see what your electrolytes appear like? Therefore, if you could only choose two things, it would be electrolytes and it would be the ultrasound. However, in this particular case, they're also going to give you more information because they want you to be able to rule out infection. Okay? They want you to be able to rule out a urinary tract infection. All right? So what they say is that you do a CBC with differential. They find that the WBC count is 12,700. The neutrophils are 68%. There are no bands. There are 6% basophils and 24% lymphocytes. We said that the electrolytes were going to be key to helping you assess the patient who has the pyloric stenosis. This patient's been vomiting, so you would expect that there would be evidence that the patient was dehydrated. If you look at the sodium, it's 129. If you look at chloride, it's 92. The bicarb is elevated at 28. The potassium is 3.1, which is a little low. Your BUN is elevated at 24, and your glucose is within normal limits. If you have pyloric stenosis, the examiners want you to know that these patients have a hypokalemic, hypochloremic, metabolic alkalosis. And that's exactly what you see here. You can evaluate that. You see that your bicarb is elevated, giving you the alkalosis component. You see that your chloride is low and your potassium is low. And what they might do on your exam is put hypochloremic, hyponatremic, hypochloremic, glucose, hyper. So they're going to mix it all up. So what you need to do is think, in a pyloric stenosis, if I wasn't sure it was pyloric stenosis, I wouldn't go to the big bucks. I wouldn't go to ultrasound. What I'd do is I'd start small with electrolytes. All right? The electrolytes would give me my information. If I've got an alkalosis, if I've got a hypochloremia and a hypokalemia, chances are I have pyloric stenosis in this child with projectile vomiting. Then you can go to the radiologist and you can say, I think that I have a pyloric stenosis. I'd like to do the best test. And your first choice would be ultrasonography. All right? The other thing that they did was the urinalysis. Because you know that oftentimes young infants who present with vomiting have a urinary tract infection. So they didn't want to leave a doubt in your mind. But what they do show you is that the patient is dehydrated. Now, the other thing that you want to know is, what if you didn't have an ultrasonographer available? What if you were at your hospital and they said, sorry, we can do the ultrasound, but it won't be read until tomorrow morning or later today? Is there any other test that would help you to diagnose a pyloric stenosis? And the answer is yes. That particular test would be an upper GI series. All right? And the significant on the upper GI series is that you would actually see an elongated, narrow pyloric canal, which would be seen as a single track. And that would be known as the string sign. So they could approach this case in a different way. They could tell you that they have a patient that has an acute abdomen. They might say to you, a string sign was present on the upper GI series. As soon as you hear that buzzword, you know that that patient has pyloric stenosis. All right, so it could be either way. But in the year 2002, what we want to make sure is that the ultrasound really would be your least invasive and your most appropriate way to make this diagnosis for the pyloric stenosis. If we continue on to the assessment, I think that the key point here that we want to be thinking about is that pyloric stenosis really is very rare in the newborn period. So if you have a patient on your examination or in your private practice who they say you're called to the nursery because of emesis, because of vomiting in a patient, already you can say the patient doesn't have pyloric stenosis. So if that's in your list of differential, cross it out or put it out of your mind because you're on computer now. Pyloric stenosis would never present in the first couple of days of life. You have to, I'm so proud of ourselves sometimes when we diagnose it early at 3 weeks of life. Usually it doesn't go undetected after 3 months of life. So but you would never find it in the newborn nursery. So if you have some problem in the newborn nursery, you need to be thinking about, do I have some anatomical problem, like duodenal atresia, the antral web? Okay? And in that particular case, in the newborn nursery, the buzzword that they're always going to be looking for is bilious vomiting. Okay? Bilious vomiting, green vomit, is never good, never good, and it's usually always a surgical emergency. Remember that for pyloric stenosis, that it's more common in firstborn males and also in Caucasians. Okay, so you know now that you have a pyloric stenosis, and what are we going to do as far as our treatment plan? Well, if you said take the patient to surgery, you would be correct, but that is not the next best step. On your examination and in practice, the next best step is to correct the electrolyte balance with intravenous rehydration. And the reason that you have to do that first is that the baby can survive with IV fluids. You want to correct any abnormalities, because if the patient or the infant goes to surgery, there's an increased risk of a poor outcome if their electrolytes are not balanced. Therefore, there's no rush. You can take your time to correct this first so that they have a better outcome for anesthesia. The second step would be to perform the pyloromyotomy, okay, the surgical intervention. The third would be to initiate feeding slowly after surgery. However, what would happen is that most patients will be advanced to oral feedings within about 48 hours of surgery. So even though we're saying slowly, we don't mean a week, all right? And so you would just start with small amounts of fluid and then advance. But these patients actually go home in a few days and do exceedingly well. All right. So we said that our final diagnosis was pyloric stenosis. And again, we're going to go through the case reviews just to make sure that we actually have the buzzwords or have key things that will help us in the diagnosis. All right. Pyloric stenosis we've talked about. What else can we say about pyloric stenosis? Well, first of all, what we can say is that there is an olive sign. All right. So on examination, sometimes what happens, especially after feed, if you feel an abdominal mass, they might say that this is the olive sign. It's the hypertrophied pylorus. All right. The other thing is that basically the patient who has pyloric stenosis will have an electrolyte abnormality. All right. So those two things that you need to remember. The other things that we need to be thinking about here are that for gastroesophageal reflux, you have spitting up and vomiting. It's usually not projectile. We said that it's usually associated with a burp, and that there may be a history of difficulty feeding. It's often associated with cough or wheezing. And usually these children who have physiologic reflux do not have any abnormalities at all with electrolytes. So you wouldn't see an elevated BUN and creatinine. You wouldn't see a low sodium or evidence of dehydration. You wouldn't see a low bicarb. And then the other thing that you want to know is that if somebody does have gastroesophageal reflux, that you could take a step to thicken the feeds, which might help to keep the feeds down, or you might end up going to medicines such as metoclopramide. Viral gastroenteritis, we said that in order for this case to be consistent with gastroenteritis, there would have been a history of diarrhea, and that the patient may have had some low-grade fevers. It's also self-limiting, and it would be supportive care with oral rehydration. As far as, again, duodenal atresia, It's bilious vomiting from birth. There's a double bubble sign on abdominal film. And also for duodenal atresia, this is sometimes associated with trisomy 21. So if you see a patient on your exam with Down syndrome or trisomy 21 who has green bilious emesis and they're in the nursery, you need to think about duodenal atresia. Our next case is going to be chief complaint, mid-abdominal pain over the last 24 hours. Let's look at our history. We have a 9-year-old male who's brought to the emergency room with a 2-day history of upper gastrointestinal upset, which began as diffuse pain and is now more localized to the periumbilical area and the right lower quadrant. Okay? As soon as you hear this scenario, right lower quadrant pain, they're brought to your emergency center. This patient needs to have a rule out of an acute abdomen. Okay? So right lower quadrant pain is significant. All right? He now denies any fever, chills, or any recent upper respiratory infection, or even any recent travel. He admits to emesis or vomiting a prior meal about 12 hours ago, and his temperature is 99.1 Fahrenheit. Now, this is mild fever, all right, low grade. His past medical history is unremarkable, and his immunizations seem to be up to date. His height and his weight are appropriate for his age. The mom states that he has been unusually quiet over the last few hours, and he has a decreased appetite. He normally has 1 bowel movement per day, but didn't have any in the last 36 hours. So that should be telling you that if somebody had a gastroenteritis, that they would be having a lot of stooling. This patient is not. So keep that in your minds. The boy is currently lying on the examination table with his lower extremities slightly flexed. He seems to have good skin turgor, so no evidence of dehydration as yet. The physical exam shows that he has a normal cephalic atraumatic head. His pupils are equally reactive to light. His sclera are anecteric. He has moist mucosa, and he has no exudates. His tympanic membranes have a positive light reflex bilaterally. His neck appears to be supple. He has full range of motion of his neck, no adenopathy, and no thyroid masses. His lungs and chest show that he has good effort. He has some slight decrease in the breath sounds on the right base. But otherwise, they're clear to auscultation. All right? Look at that. Pick that out. Because they're wanting you to be thinking that maybe he has a pneumonia. Because remember, pneumonia can be associated with abdominal pain. So just hold that in your thoughts. His heart appears to be within normal limits. His abdomen shows a slightly hypoactive bowel sounds. He has right flank rebound tenderness. All right? Another differential diagnosis. They're putting this in to make you think, could he have some kind of a urinary tract infection or a pyelonephritis? Because that can be associated with abdominal pain. Okay? He has diffuse periumbilical discomfort, and he has right lower quadrant with localized tenderness. Now, his pain is dull, and there's no radiation. The pain, however, is slowly starting to worsen. It further worsens with coughing. It's also worsening when he flexes his hips. If you do a rectal, which you must, then you're going to find that he has focal tenderness on gentle palpation. His extremities show no evidence of edema, clubbing, or cyanosis. However, he does have slight discomfort with right lower extremity flexion at the hip. All right? So what does that mean? If you flex the hip, and if you would adduct it out, the obturator sign is positive. So we're going to be thinking about our differential diagnosis. As you went through your scenario, you were picking out things that might be associated with this young man who had the abdominal pain. And so the first thing that we thought about or could think about was gastroenteritis. However, we're thinking that that may be low on our diagnosis because there's no diarrhea. And he only really had one episode of emesis. The other thing is that you need to remember that Yersinia and Campylobacter can both mimic appendicitis. So keep those thoughts. Other things. Constipation can cause abdominal pain. Maybe this patient has constipation. He's not had but one bowel movement in the last 30-some odd hours. So could that be it? Could he have a right lower lobe pneumonia? Because we saw on the physical exam that he had some decreased breath sounds in his lower base. And you know that you can have a referred pain with pneumonia to your abdomen. Could he have mesenteric adenitis? Well, with mesenteric adenitis, there may be some previous history of having some viral illness, and we're not really picking this up. Could he have the urinary tract infection? If you think about your physical exam, you know that the person did have some flank tenderness. Flank tenderness might go with pyelonephritis, so I need to consider this in my differential diagnosis. The other thing that you need to be thinking about is, does this patient have an acute appendicitis? Now you're going to say to me, well, Dr. Kerner, I only have a minute to think of the diagnosis, to think about what the next step is. I've got so many things here that they're confusing me about that I wouldn't even really know where to start. And what you need to be thinking or hone in on is this right lower quadrant pain. You must, no matter what it's associated with, poor breath sounds, flank pain, you must rule out the acute abdomen. You must assume that this patient has an appendicitis. All right? And so start with that as your working diagnosis and think about other tests that you could order or other diagnostic studies that you could order that would aid you in confirming that particular diagnosis. Pancreatitis would be another option for the differential diagnosis. However, I just want to point out to you that it would be a rare finding in a child. Okay, what's my plan? If you could only order 2 tests, the surgeons say the test that you need for those surgeons to make the diagnosis of appendicitis would be your complete blood count and a urinalysis. I'd like to qualify it and say that if this is a female who is menstruating, the patient also needs a pregnancy test. All right? So in this particular patient, they're giving you more information so that you can rule in or rule out those other things that you had a doubt about. All right? So we're going to look at CBC with differential. We're going to look at the urinalysis. We're going to look at electrolytes. In this case, they ordered a plain abdominal film. Not necessary. Would be low in the next step. That would be the least thing that you would want in most cases when you're diagnosing appendicitis. They're going to get a chest x-ray because of that questionable decreased breath sounds. And in this case, because we also considered the possibility of pancreatitis, even though we said it was a very low possibility, they're going to get an amylase and a lipase. However, if in some instances the examiners will give you some of this information and they'll let you order the next test. The 2 tests that you need are the CBC with differential, urinalysis, and if it's a menstruating female, the pregnancy test. Okay, let's look at some of our results. Well, first of all, if we look at the CBC, we see that we have elevated white count. We have 16,800 white blood cells. We have predominance of neutrophils, which is 78%. We have no bands. We have 9% basophils, 8% lymphocytes, and 4% monocytes. If we looked at the electrolytes, we would see that we had an elevation of the BUN. Our urinalysis is normal. They did the abdominal film, and it showed indistinct psoas margins with possible air fluid levels in the right lower quadrant. Okay, so they're trying to give you a little bit of help. However, no fecalith is seen. And remember that the abdominal series or the abdominal film is not helpful in diagnosing appendicitis unless you see, for the definitive diagnosis, unless you see the fecalith. And not every appendicitis will have a fecalith that shows up on abdominal film. All right. What else did they do? We said that they did a chest x-ray because they heard decreased breath sounds. However, there were no infiltrates that were present. Therefore, this pretty much rules out your pneumonia. And the last thing that they did was amylase and lipase, and that's also normal. So how would we assess this? Well, we've been doing it all along because this is a dynamic process. And since you only have limited time to make that decision on your exam, you need to be assessing as you go along in your history. All right? And we've said the absence of diarrhea makes infectious gastroenteritis unlikely. We said that there don't seem to be any respiratory symptoms or abdominal findings that are going to help us, but that the chest x-ray most likely excludes pneumonia. We said that we didn't really have any history of an upper respiratory infection, so mesenteric adenitis probably is unlikely. And the absence of findings on our urinalysis makes a urinary tract infection pretty much unlikely, even though the patient did have flank tenderness. Now, think about it. Who are they examining? They're examining a 9-year-old. If you've ever examined a 9-year-old in your offices or in your practice or during your medical school, you know that if you ask a 9-year-old, does this hurt? They say yes. All right? Does this hurt? They say yes. And so, therefore, this test result probably should steer you in the right direction that there is no urinary tract infection. All right? Now, if we continue our assessment, look at your characteristics of pain. First of all, initially you had epigastric pain. And over a period of time, that pain went from epigastric to periumbilical and then into the right lower quadrant. Okay? This is so suggestive of appendicitis. The other things that suggested are the air fluid level, which is showing some type of indistinct psoas margin. And it's also suggestive of an inflammatory process because the patient is having a paralytic ileus. Now, this is controversial, but you need to do what is best for your patient. If you have a pediatric patient on your exam, I would tell you that in order to determine, the first step is call surgery. Can the surgeons clinically diagnose the appendicitis? If they feel that they need an added diagnostic study, the best diagnostic and the most preferred diagnostic study for a child would be the ultrasound. All right? Now, remember, you want to do the least invasive. All through this test, what you should be thinking about is, and all through your practice, what you should be thinking about is, what is the least invasive thing that I can do in order to get to the answer? Okay, that's what you'll be graded on. All right. Now, On occasion, if the clinical exam is equivocal, on occasion, if the ultrasound is not helpful, your next step would be the CAT scan of the abdomen. All right? So the CAT scan should not be your first choice on the examination or even in your clinical practice. Why? Because many healthy children are going to have a non-filling appendix. And that's what you're looking for on CAT scan to make the diagnosis of appendicitis. Therefore, if you're looking for non-filling of the appendix, and many healthy children have it, you're going to be taking a lot of children unnecessarily to surgery if you're depending on that CAT scan. So the CAT scan for children is not as helpful as it might be for the grown-up. All right, so as far as the ultrasound, what were our results? Well, we're looking here and we see that it showed edema and inflammation of the appendix, which is just what we would have expected to find. What would you be expected as physicians to do as far as your steps for treatment? Anybody who comes in who has abdominal pain in the right lower quadrant and you're suspicious for appendicitis, you need to be thinking about giving IV fluids to correct any dehydration and any electrolyte abnormalities. Also, if this patient is going to surgery, they may not go to surgery immediately, right? The surgeons may have a couple of cases ahead of them. Therefore, they might have to wait 6 or 8 hours. You would never let somebody who has appendicitis eat. Therefore, you want to make sure that the minimum you give them is maintenance IV fluids. And of course, the definitive treatment for a person who has appendicitis would be an appendectomy. Now, the question you might have for me is, should I give any antibiotics prior to the patient going to surgery? And the answer would be, you would give the broad-spectrum antibiotics if you suspected that the patient has perforated. Oftentimes in the population with whom I work, they wait a long time prior to coming in. They might be 4 days into these right lower quadrant symptoms. And so we see a lot of perforation. And so in that particular case, we would give antibiotics. However, if it's within the 24 hours and the pain we've watched is just progressing, we have no suspicion for that. We don't have a severely elevated WBC count without bands, then we probably would not give the broad-spectrum antibiotic, okay? And we would leave that up to the surgical care. But that would go above and beyond what your intervention would be, all right? So the main things are fluids, appendectomy, and then decide if there's a perf if you need antibiotics. What other things do you want to be considering? Person who comes in with abdominal pain is in pain. And after the diagnosis is made, you really should try to provide some comfort. And so pain medications preoperatively for comfort would be allowable. Now, we've been discussing the assessment of appendicitis. Just a few other key points for you to remember is that when you're doing your physical diagnosis, some of the pertinent positives that you would want to include would be, does this patient have rebound? Does this patient have tenderness? How are the bowel sounds? Does the patient have an obturator sign? Does the patient have a psoas sign? Does the patient have a rectal that's suggestive with some tenderness that might be predominantly on the right? Remember that you're going to guaiac the stool. Why? Because especially in this age group, a 9-year-old or a 10-year-old, these children sometimes can get a colicky abdominal pain, and when you do the rectal exam, you see that there's an occult blood. In this case that I'm trying to get at, if the patient was short or failing to thrive, that would be consistent with Crohn's disease. So you want to make sure that you do your rectal. All right? Also, if you had blood with the stool, it might lead you to more of a gastroenteritis. So the rectal would be an important part. Remember that for appendicitis, that it peaks in the children between 9 and 11 years old. It's important to know that in children less than 4, that we sometimes miss the appendicitis initially. We diagnose those as gastroenteritis. And so those children usually come with perforation. Okay? So if they have a child on your exam who is 2 years old and they've been diagnosed with gastroenteritis, and then come back and now all points to an appendicitis, you need to suspect that they probably did perf and that those particular children would need broad-spectrum antibiotics. All right? What other things do I want you to remember? Remember that the abdominal x-ray is not that helpful for appendicitis, and so that would be a lesser step that you would do. All right, now, we've said that the final diagnosis was acute appendicitis, and in this particular case, without perforation. However, we're going to go through our case review, just pick out some key or buzzwords that might help you or be useful while you're ruling in and ruling out your diagnosis. All right, the first thing that we're going to look at is gastroenteritis, and the key for that is that diarrhea and vomiting are usually present. Constipation, the patient may have a history of constipation. And when you palpate the stool on rectal exam, what may happen is that you'll feel hard stool in the vault. All right? And so that would be important. The other thing is that for constipation, the rectal is really non-tender. All right? There may be some discomfort, but it would not be specifically tender on the right side. And again, if you did abdominal films, what you would see is stool throughout. Other things, pneumonia. We've talked about cough and fever. Whenever you have fever, cough, and tachypnea, that's the triad for pneumonia. So on your exam, they will write fever, cough, tachypnea. The other thing that you need to be thinking about is that the leukocytosis will be elevated. You want to make sure that you look at the chest x-ray to see if there's an infiltrate. Other things that we're thinking about here are adenitis, but we've talked about a pharyngitis or an upper respiratory infection being present, and the urinary tract infection. We said that a patient who has abdominal pain might, in this age group, might have a urinalysis that's positive for a UTI. Pancreatitis is seen very not frequently at all. I would say it would be a limited diagnosis in the pediatric population. And there's pain that's usually higher, and it's not in the right lower quadrant. Your amylase and your lipase would be elevated. And so this really will lead us into our next case, why is my baby yellow?